as a guest. Okay. I'm Dr. Faryal Siddiqui. I work at La Jolla Cosmetic Laser Clinic. Like Dr. Asha said, I'm recently transplanted from Texas. So I did the reverse migration, Texas to Southern California. But I am enjoying the weather. I love our new clinic. At this clinic, I do a mix of general dermatology and cosmetics for the most part. I also do some surgical derm, like basic excisions or skin cancer management. Currently, I see patients of all ages. I do cash pay procedures and I also take insurance as well. So that's a fun thing about dermatology and my job is that there's a good variety pretty much every day between what I'm doing and who I'm seeing. And I'm very excited to speak to you guys today about hair loss. It's a very complicated topic that I know it's really hard to get good information on it. There's almost resource or option overload when it comes to trying to understand what's going on with our hair. Let me get used to these controls. So hair loss, the medical term for it, you might have heard it already, but it's called alopecia. So you'll hear me refer to hair loss kind of as hair loss and alopecia throughout this talk. But the main umbrella differentiator between the types of hair loss is whether it's scarring or if it's not scarring. So the majority of hair loss is non-scarring, meaning that perhaps you don't see hair there, but the follicle still exists. If I were to look under your skin, it's still the right environment for hair to at least grow back or be present. Sometimes, rarely, we get scarring hair loss, and it's a much more difficult disease because in addition to losing the hair shaft, you don't even have the ability to have a hair follicle in your skin. So I'll kind of talk about the differences between those later on. There are so many things that can cause hair loss. The majority, like the most common cause, is what I think we commonly refer to as hormonal hair loss or just age-related hair loss. That'll be the main focus of my talk. But hair loss can also be a sign of something else going on. It can be reflective of underlying disease. It can be caused by starting a medication or stopping a medication or an acute life stressor. It can also be reflective, like in late adulthood, of stuff that you were doing to your hair when you were in a young adult, perhaps. And some hair losses are really easy to address, and some are just very, very difficult for both the patient to deal with and the physician to try to help with as well. So lots of variability when it comes to hair loss, period. So what you may perceive as hair loss can be made up of different things. So a variety of changes can make you just look like you don't have as much hair as you used to. The most common is like a true density loss, meaning that you just don't have as many hair follicles present on the scalp. What can also happen, what commonly happens as we age, is that the hair shaft thins, and this photo kind of demonstrates that. On the right, we have this big, fat, dark terminal hair. So the hair on our scalp is what we refer to as terminal hair. Sometimes it can make a transition from that kind of hair shaft to that really thin, wispy hair, which is in the middle of this photo, and we call that a vellus hair. So sometimes your hair is still there, the follicle number is still there, but now your hair has made this transition and it's just less visible. It's covering your scalp skin less. There's also changes that can happen to our hair shafts, whether it's like genetic or acquired, or we induced it with styling or whatever, but we can mess with our hair shafts to the point where maybe your hair is breaking, maybe an inch or two off of your scalp, or maybe halfway down the length of the hair. So now it looks like you have less hair, but really it's just the hair is breaking. And then sometimes, and I'll talk about the hair cycle, I think on the next slide, but sometimes we lose some of our growing part of the cycle. So the hair just may not, the people come and tell me, my hair is just not as long as it used to be. I leave it alone, I don't, and just long. And so sometimes that's what they're experiencing. So the hair cycle is pretty complicated, but basically there's a growing phase, which is the anagen phase, and that's the longest phase. So the majority of your hair, like 95% of all the hair in your scalp, is hanging out in your resting phase, meaning that it's there, everything's attached, it's slowly growing, and then it'll very promptly transition to this intermediate phase called catagen. Very few hairs are here, maybe like 1, 2, 3% of all your hairs are in this phase at any given time. And then there's the resting phase, which is called telogen. And I'll bring this up later because this particular phase is kind of important for a variety of hair losses. But it's this hair that sort of is falling out. It's like the resting phase and it falls out after it's done resting and it prepares for a new cycle. What's important to keep in mind is that if you took all the hair on your head, they're all doing their own thing. Each hair follicle is on its own independent journey. So some might be an anagen, some might be in telogen, some hair follicles might be empty, that kind of thing. And the hair cycle is genetically determined. So for any given person, their ability to be in anagen phase, meaning how much they can grow their hair, is genetically determined. So people say, I just can't get my hair as long as you can. There's truth to that statement. The first kind of hair loss I'm going to talk about is essentially that hormonal or age-related hair loss. The medical term is androgenic alopecia, which I'll refer to as AGA moving forward, but there's also the term like male pattern hair loss or female pattern hair loss. So just to keep it separate to make it simple for everyone, I'm going to refer to male hormonal hair loss as androgenic alopecia, and I'm going to refer to females as female pattern hair loss, even though they're kind of like interchangeable terms, but just to make it easy for everyone. This is super common. It affects the vast majority of men, like 80% of men and about half of women by age 70. So it's very prevalent and it's inherited from either one or both of your parents. There's multiple genes that can be involved, but I think the two best established are for men, it's the androgen receptor, and for females, it's aromatase. And that's probably details that you don't care to know, but there's a lot of factors that can be involved. The good news is that this particular type of alopecia is non-scarring, meaning that we have capacity to treat it. Male androgenic alopecia, there's two main players, two entities that really determine what happens to a male and his hair, and that's testosterone and dihydrotestosterone. So testosterone, very commonly known, hormone, it's responsible for our muscle mass. As we kind of go through puberty, it's your voice change. It's also responsible for your sex drive. And it has to do with the terminal hair that you have in certain areas, like your underarms. Dihydrotestosterone, or DHT, is responsible for prostate growth, which is important, and hair growth kind of in the non-scalp area. So beard, your ear, your nose. But interestingly, it's associated with scalp hair recession. So the balance of these two is kind of the main factor. So men develop hormonal hair loss when they have an increased rate of conversion from testosterone to this DHT within the hair follicle specifically. And the enzyme that's responsible is the 5-alpha reductase type 2. So the lucky men who just don't have this enzyme present, just don't have it, it doesn't exist, they don't get hair loss. And that's just because they don't have the conversion going on. They don't have the DHT present within the hair, causing it to shrink and become a vellus hair and just not be noticeable. This is pretty far gone male pattern hair loss or androgenic alopecia. And the consistent pattern is one, vertex thinning, which you can see on the left. And then two, there's this frontal hairline regression. So the frontal temporal hairline, which is basically the two sides of the forehead, that tends to go backwards in a triangular fashion, and the whole hairline will also retract backwards. In some cases, or when it's really far along, the hairline regression may meet up with that vertex thinning, which kind of gives people that appearance of just having a rim of hair around their head and nothing in the middle. The male pattern hair loss is, androgenic alopecia is graded on this scale called the Norwood scale, and it's really variable where you land on it, but this is kind of what we do objectively to tell where people are in this hair loss when we evaluate them. The most tried and true therapy, I'm sure we've all heard about it, is Rogaine, and that's the brand name, and the generic is called minoxidil. For men, it's typically 5% either solution or foam. It's FDA approved for usage for this. What typically is done is like one syringe worth is typically a milliliter. So you put it on wherever you're losing hair twice a day. And it's fairly safe. The most common side effects, if you do end up getting any, is that perhaps you're dry where you're putting it on, or maybe you get a very rare like scalp irritation or a contact dermatitis. What I warn everyone when they're about to start minoxidil is that it'll get worse before it gets better. So it causes this initial paradoxical worsening of hair loss for upwards of like 1 to 2 months. And what's happening, if you recall that hair cycle slide, is all those hairs the 15%-ish of your scalp that's hanging out in resting phase, all of those will exit the room kind of when you're using minoxidil, because it has to make room for a new bulb. Because what your scalp wants to do when you're using minoxidil is it wants to go back to growing phase. So to get back to growing phase, everyone who's resting has to leave. And so when people tell me, I tried minoxidil, but I just lost all this hair at like month 2, so I stopped, I have to explain to them that that was happening because it was working, which is, difficult for someone who's kind of going through acute hair loss, or maybe it's really an emotional experience for them. But I tell people, like, if you can just power through, that's when it really starts to work, is after you get past this tough phase. If you use minoxidil, I give people a big lecture on this too. It has to be used sort of kind of forever, because it works against what you are genetically predisposed to doing. So if you stop Rogaine after a few years of usage, thinking, hey, you know what, a lot of my hair came back and I'm happy with where I am, you will catch up to where you would have been had you never used it. And so to the patient, it might be this very sudden, very noticeable loss of hair. And it's not compounded hair loss. It's not additional hair loss. It's you kind of going back to baseline, to your natural genetically determined baseline. And so if you're going to do Rogaine, it's a marathon. It's not a sprint. A very common oral treatment for male pattern hair loss is Propecia, which was a rebranded finasteride. Finasteride originally came out to treat prostate enlargement. It's a synthetic anti-androgen, which, if you recall, inhibits that particular enzyme that we mentioned was important earlier. It is approved in tablet form for this indication, so for male androgenic alopecia, and it's usually like a 1 gram pill daily. It really significantly impacts male hormonal hair loss. It halts hair loss in upwards of 90 patients, and more than half will actually experience some regrowth. Like minoxidil, it's you have to take it forever, kind of, if you want to keep up the gains, because the gains that you make will be lost upon discontinuation. There is an important note, I think, with taking this medication in regards to PSA. If there's any men on the Zoom that get this lab monitored, Propecia can sort of falsely lower your PSA level. And so that's something to keep in mind when you're kind of assessing the level on your blood work, or you should let your physician know, if they don't know that you're taking it, that finasteride's on board. Overall, I read a few articles about it. I consulted with a few of my urologist friends, because there's talk about perhaps Propecia doesn't change the risk of prostate cancer, but it kind of increases the risk that if you end up getting a prostate cancer, that it's a higher risk cancer, if that makes sense. So overall cancer risk is either the same or lessened, but chance of a worse cancer is associated with taking this, which I know can be confusing. But that's just something I like to mention, that let whoever is monitoring your regular blood work know that you are on this for hair loss, because it could be important. Some of you might have heard about post-finasteride syndrome. It's kind of, I think it's a controversial entity that is getting increasingly recognized. It's this constellation of just not desirable side effects. So they mostly revolve around sexual adverse effects, like erectile dysfunction or decreased libido, plus minus like some depressive symptoms. It's what causes it. I found this article that kind of illustrated that there's like differential genes expressed in the patients that ended up developing this after taking oral finasteride. There's not a really great treatment, unfortunately. I've never had a patient of mine experience this, but I know someone personally who took a very short course of finasteride and really feels like this happened to him. And it really affected his life in a non-ideal manner. So I am very empathetic to these kind of symptoms, and I wish that there was like more recognition of it and a better protocol for how to address it. But currently, I don't think there is one. So I also counsel people that are going to take it or are already taking it, that this may happen, kind of irrespective of the dosage and the length of the course that you're taking. Moving on to female pattern hair loss, it has similar hormonal cause. It's due to the male hormones that are kind of floating around as well. It usually starts around or shortly after menopause, but it can start earlier if there is a strong family history of hormonal hair loss. It looks a little bit different than the androgenic alopecia we see in men. It's more the diffuse thinning of the crown, and there's a widening of that midline hair part. There is retention of the frontal hairline, unlike what we see in men. That recession, that triangular recession kind of near both of your temples is much less commonly seen in women who are experiencing this. And what they also experience is the transition from that terminal hair, that thick pigmented hair, to these little wispy, thin vellus hairs. These are some photos kind of illustrating what I was talking about in terms of the midline part widening and sort of the thinning around the crown of our scalp. And you can see in all these women, their frontal hairline is still intact. The women's hair loss is graded on a different scale. This is the Ludwig scale. And again, it's just measuring the degree to which the midline part or the middle crown is sort of widening and getting thinner. This is another Sinclair scale for the same kind of pattern of hair loss. And what we refer to on the left is a Christmas tree pattern. So it's midline thinning, widening of that hair part. And there's usually an accentuation of that widening directly near that frontal hairline, which kind of gives this appearance of this like upside down triangle or the Christmas tree. The first steps in treatment are similar to that for men. So minoxidil is a great treatment option, especially if it's mild or the patient's younger. This is very early. It's used a little bit differently. So my protocol for women is 5% either foam or solution, and you use it on the scalp once daily instead of twice daily like it is for men. Women are a little bit more susceptible to growing facial hair if that minoxidil ends up accidentally on the face, which is very easy to do if you're using the solution form. It'll go away with discontinuation of the treatment, or if you're just diligent about not getting it on your face, it's not permanent. There are a lot of oral treatment options that people can utilize, with the exception of if they're trying to conceive or breastfeeding or pregnant. And those are oral contraceptives. That's very common, very easy. Spironolactone is traditionally like a blood pressure medication that also got rebranded as this like hormonal acne medicine that has really good efficacy. And it also has this nice hair regrowth or hair loss prevention indication. And finasteride and dutasteride can be used as well. Dutasteride being a similar medication that inhibits two enzymes instead of one. It's a little bit controversial for use in women, but it has been utilized. It's not my go-to, but it does have some evidence to work. I wanted to include a slide on this just because the minoxidil pricing, when it's marketed to women, can sometimes be different for no reason other than the box. And so I wanted to include discussion on the pink tax, because minoxidil, when it came out, it's been out there forever at 5% for men. And when it got rebranded for women, they knocked it down to 2% twice a day instead of 5% twice a day. And the thinking was that it was working just as well. And at the 2%, there was less chance that a female would get this unwanted facial hair, which is fine. I have no problem with that. But women's extra strength minoxidil came out at 5%. And it ended up being very much more expensive than men's 5%. And so there was actually like a research letter that I found detailing this, that the same medication at the same strength with the same active and inactive ingredients was actually more expensive for women, even though they'd be using less of it. And so I actually went to a few stores like Walmart, Target, when I was preparing for this presentation to see if that was still the case. And I think there's a little bit more equivalency in pricing now. But I do recall a few years ago looking for some minoxidil and really thinking that it was unnecessarily $5 to $10 more just to get a box that was pink or maybe a little bit shinier. So when I tell women to get minoxidil, I tell them to go get the most boring man minoxidil that they want to use, because it kind of avoids this whole issue. I get asked this a lot, where to buy minoxidil. I have no stock in minoxidil or Costco or anything, but to date, the cheapest I have found it is this particular Costco supply. So it's the solution form, it's 5%, they give you 6 bottles, and it's priced at $18. You do have to get it online. It's not carried in Costco stores for some reason, but with the $6 shipping, you're looking at 6 bottles for $24, $25. And I believe it's a 6-month supply for men. And if you're a woman, I mean, that's a year supply. So to make your life easier, I tell people, if you're going to do it, you're going to end up doing it for the if you get the $25 a month bottle. So just go get the cheap stuff. I don't really have a preference between foam and solution. That's very much a patient preference. Foam tends to be a little bit more expensive. I think for women, it's a little bit easier to get solution with the dropper in between our longer hair. This is another brand that I get asked about all the time. I think it's a few years old at this point. It's called Vegamore. They kind of claim to be like a natural alternative to minoxidil. And so their key ingredients are these plant derivatives, mung bean, curcumin, which is the active compound in turmeric, and then red clover, which has this antioxidant, which I think hair follicles are particularly responsive to. I really perused their website to do a slide on them, and it was unclear what their evidence was for their claims. But I think their main selling point is they're like a natural inhibitor of DHT, unlike minoxidil, which is an inhibitor of DHT and perhaps an unnatural mechanism. It's priced pretty differently, so it's a $50 to $60 a month commitment. And when I was going through a bunch of forums and blogs of people who had used this, what I found over and over again was that people who had their subscription service were not even getting the 4 weeks out of the bottle. So it seems like that's the price for like a 3-week supply. So I just like to tell people that when they ask me about this particular brand. I have no personal experience using it, and I don't really even know anyone who has used it. But they have very elegant advertising, and I think it's a pleasant brand experience. So I don't discount that. When someone enjoys what they're using, they're much more likely to use it. So if someone will pick up this bottle and actually use it, unlike perhaps that plastic bottle from Kirkland, then I tell them to go for it, because ultimately nothing's going to help you if it's sitting in a cabinet somewhere. But I don't have a lot of opinion on this personally yet. Anyway, the other question I get asked all the time is supplements. And I put in this non-exhaustive list of supplements that can be used just to illustrate how many can be used. And it's difficult for me to because supplements themselves are not standardized. They're not standardized in their formulation or where they were sourced from, or if they have fillers or not, or if it's a capsule versus a pill versus a gummy. I can't quantifiably tell someone how bioavailable their supplement is. So it's difficult for me to really advise on one brand versus the other. But in particular, I get asked about biotin all the time. It's a water-soluble vitamin B7. It's any excess that you intake. If your kidneys work, it'll be excreted in your urine. So in the absence of organ disease, I don't really have a problem with you taking a bunch of vitamins. It's very uncommon for people in America and like Western diets to have a true biotin deficiency. There's a few instances where people can actually have a deficiency, and those are like genetic defects in the ability to absorb it. That is typically known kind of near birth. So it's not something that perhaps you would have gone through your whole life without realizing. Usually people know when they're very young. You can actually induce a deficiency, interestingly, like if you're someone who is really pounding raw egg whites. I think for a while that was like kind of popular in protein shakes. Raw egg whites have a glycoprotein called avidin in it that can actually bind to biotin and render it not absorbable in your body. So that can actually happen just by what you're eating. And then certain people on certain anticonvulsant medications like phenytoin or carbamazepine, that those medications can interfere with absorption. So it can happen in certain instances. People ask me about taking it. My opinion kind of is it can't really hurt, but I do warn people that there's kind of one very specific situation where it can cause a problem. And there was a few studies done that showed that, high dose biotin supplementation can falsely lower your troponin test. So, God forbid any of you are having chest pain and you are worried you have a heart attack, and you go to the ER and you're saying, I think I have a heart attack. And they draw this blood test to see if you truly do or not. It can be falsely negative if there's a lot of biotin on board. So I tell people, if you're going to take it, most of the time people who are asking me are 30s and 40s and generally healthy, and I'm not worried about it, but I do preface, if the day comes that you're having chest pain and you're really worried and you're taking biotin and somebody tells you your blood test is negative, therefore you cannot have a heart attack, just really like advocate for yourself and let them know that you are on a supplement that can make it falsely negative. It is very specific. It has never been clinically relevant in my case, but it's something to keep in mind. And the supplement dosage that was studied for this instance is available over the counter. So the study dosage was 10 milligrams. Most supplements that you see in the supplement aisle are ranging like 1 to 5 milligrams, but it can be confusing because, as I showed in this photo, these bottles have micrograms listed. So this conversion between micrograms and milligrams, it can get confusing for the patient. This bottle is 10 milligrams, and that's the dose that could have given you a falsely negative heart attack test. So just something to keep in mind on the off chance that it's ever relevant. Nutrafol is this new medical grade nutraceutical. It's a combination supplement. I believe it came out maybe 4 or 5 years ago. It is only carried kind of through their website and in physician offices. I am a little bit more comfortable recommending this just because I know where it is sourced from, and I know that it's sort of controlled where it's dispensed. So I'm not really worried about like fake products that are full of weird things being sold to people. They actually do have like scientific evidence published that in this like randomized double-blind placebo-controlled study, there was improvement that was found in third-party objective observers. And so I put in this blurry zoomed in the back of the bottle just so you can kind of see these different things in there that is their claim to fame. I actually take this myself. I am only on my 4th bottle or so. I just started my 4th bottle, and the company, the rep who comes by our office has said, it takes about 4 to 6 bottles to really make an assessment on whether it's working for you. So I don't have my own personal opinion yet, but I have not had any issues. It's sold in our clinic, and if someone really wants to take something by mouth, I'm like, I would rather you get this than like something just random off Amazon, just because I know where this one's coming from. This was another study that I found just illustrating that supplementation of certain nutrients can actually be helpful. So these women in particular, they took omega-3s and 6s, and they took this mixture of vitamin antioxidants, and they did it for about 6 months. And the change is subtle, but it's definitely an improvement. So I put this in here to not really knock down the role of supplements when we're looking into really chronic hair loss. They can help. Moving on, hair loss is, fairly common and for the most part innocuous, but people do ask me like, is this a sign something worse is going on? There's a few instances where you should be consulting with a physician or just thinking about perhaps another diagnosis, and I listed those here. So if you have symptoms or signs of hyperandrogenism, so that meaning that you just have too much male hormone going on, that's kind of like a PCOS clinical picture. Like you might have thick hair on your chin or the sides of your cheek, or you have like inappropriately resistant acne, or perhaps your frontal hairline is receding in a male pattern. Those are all things to mention to a physician. Hyperthyroidism symptoms are kind of just like everything's revved up. You're losing weight when you're not trying to, you can't sleep, you're feeling anxious, your heart's beating really fast. That can be something to mention to a physician. And then any signs of autoimmune disease, which I know basically encompasses like potentially any symptom. But if you are having ongoing joint or muscle pains, or just fevers you can't explain, or getting weird rashes, that can be associated with hair loss. And in all of these, I just say to keep in mind and always advocate for yourself with your physician if you're experiencing any of these other symptoms. So this hormonal age-related hair loss, it's like a clinical diagnosis. The main differentials, which I'll talk about in coming slides, are alopecia areata and telogen effluvium. Certainly there's 500 causes of hair loss, but these are the main 2 that to consider when we're kind of looking at this clinical picture. If there is a question regarding diagnosis, as I mentioned earlier, we can work it up a little bit more thoroughly. So typically blood work, and that would be like a hormone panel, iron panel. We can always get vitamin levels, we can get a thyroid panel, and we can always do a scalp biopsy, which sometimes doesn't help, but sometimes it very clearly demonstrates something else going on. I put this slide in here just to kind of go over a few slides of elective hair restoration therapies. In our clinic, we cell injections, and we're trialing some early like laser treatments. We don't do hair transplants, but they're available throughout San Diego. Perhaps we'll offer it in the future. But these restorations are typically considered cosmetic, which means that they usually are at cost to the patient. But in our clinic, and I imagine a few others, you can utilize your FSA account if you have one. Starting with platelet-rich plasma, maybe some of you have heard of like the vampire facial, that's similar. So it's your own PRP, meaning that we draw your blood just through your arm and we spin it down in our own centrifuge machine in our clinic. We extract, like separate and extract and discard your red blood cells, and we keep this plasma serum behind. And that plasma has platelet-derived growth factor and TGF-beta and VEGF and IGF, all these growth factors that we know modulate the hair growth pathways. They shift your hair matrix into like a favorable growth pattern. What is typically done is an induction dose. So that's the series of monthly cycles for about 3 or 4 months typically. So you come in once a month, we get your PRP ready, we inject it into your scalp. After that induction, the treatment needs to be maintained, and that maintenance is usually every 6 months or so. So it does require a commitment, but it's a little bit easier on your schedule, I guess, and you have to think about it less often, but it does also take maintenance. This is just a little photo kind of illustrating the process. So we take your blood, spin it down, we keep that yellow, the platelet-rich plasma portion of it, and that's what is really helpful to your hair growth. These are some before and afters from my own clinic. These are actual patients of ours who had gotten PRP done. So you can just see like increased hair density, hair thickness, just good scalp coverage. These patients were all very happy, and we are very grateful that they were willing to share their photos so you all could see them. Here are some more before and afters. So the one on the right is a woman who I might have had some hair plucking disorder as well, or maybe just some traction, but she responded very well. In our clinic, we're fairly unique in that we offer stem cells in addition to PRP. So it can be used exclusively, it can be mixed with your own PRP. And from our own experience, people get more robust results. They're sourced from donated human umbilical and placental tissues. We get them from a third-party lab. We don't do it. We don't make it ourselves, but we get it from an FDA-approved lab. And the stem cells contain naturally present cytokines and growth factors and other kind of proteins that are supposed to be helpful to hair follicles, to the hair matrix, to get it back into a growing phase. Hair transplant, again, we don't offer it specifically, but I did want to cover it a little bit. Surgical restoration is, I think, totally fine if it's something that you want to do and you have failed conservative measures. If you have tried like medical therapies or minoxidil, say, and you haven't had the improvement that you want. Not everybody is a candidate. There's a few things that really determine whether it's going to be a successful transplant or not. And that's one, what's the cause of your hair loss? If you have some weird autoimmune thing going on or some inflammatory thing, like a hair transplant is not appropriate until that's addressed efficiently. The extent of hair loss or the potential for ongoing progression is also important. People respond particularly well when the majority of their hair loss is sort of frontal hairline. That frontal hairline is much easier to restore than the vertex. And I think people generally get a better outcome. You have to have actual donor hair. So if there's no hair present, say in the occipital scalp or the back of your scalp, then you're not a candidate. But if you have a lot of hair, then you have a lot of hair to move around. And then hair color and texture also plays a role. If your hair is blonde or red, or you're in like a salt and pepper phase of life, then that actually works better than just light skin, dark hair, because there's less contrast. And if you have curly hair or textured hair, that actually gives you the appearance of a lot more scalp coverage than say like straight hair. After transplantation, you're going to go through this post-transplant hair shedding again. And then the hair begins to grow back at like 4 months, but there's a lot of variability. I tell people to give themselves anywhere between 10 to 20 weeks to get their hair regrowing. And the full effect is really going to be present at somewhere like 6 to 9 months. hair transplant does not halt your hair loss. So if you have really active hair loss or you're getting the hair transplant, there's capacity that you lose more hair around the transplant. And that's a tough situation that a few men find themselves in, usually requiring a second transplant. So that's why I tell people if they're going to go through the expense and effort of getting a hair transplant, they should be maximally on other treatments. Like they should be doing minoxidil. They should already be on Propecia if they can manage to take it. So just to maintain their transplant and to prevent hair loss around it. This is actually a book chapter that I co-authored called PRP and Hair Transplants. And the focus in my chapter was just to see how those two elective treatments did when they were combined. And the basic takeaway of the research that went into it is that using PRP kind of during any step of a hair transplant typically yielded better results. So some people used PRP as a primer and they injected it into the scalp prior to injecting the little transplants. Some people used the PRP as a bathing solution while they were preparing to transplant them, etc. So the basic takeaway is that they work really well when they are used in conjunction, which goes with what I was saying, that really, if you're going to go through this kind of stuff, you should be on multimodality treatment just for the best response. Another very common culprit, which I think is probably the second most common thing that I see when it comes to hair loss, is telogen effluvium. So it is sudden, intense hair loss kind of diffusely throughout the whole scalp. It's typically like 2 to 3 months, upwards of 4 months after really anything stressful. So very commonly this happens to women after they give birth, 3-4 months later, they lose all their hair. This can happen after any severe illness, any like really high fever, if you had a surgery, if there was a divorce, if someone that you loved passed away, starting a new medication, stopping a medication, etc. In older women who maybe experience telogen effluvium for any reason, it might actually unmask existing female pattern hair loss that they didn't know was brewing. And a few patients rarely, unfortunately, do transition to chronic telogen effluvium. I will tell you this has happened to me twice. In 2018, I accidentally went on a crash diet. I really didn't mean to. I had heard about intermittent fasting. I got way too enthusiastic about it. And I kind of like shortened my eating window too much too soon. And on schedule 3 months later, I had massive, massive hair loss. So I'm very sympathetic to this because it is very frustrating and it's real and it's hard to deal with. Just going back to that slide about the hair cycle. So again, you have like 10-15% of your total scalp is hanging out in this resting phase. So if something weird happens to you, something stressful happens to you, you might lose that whole 15% at once, which is kind of a remarkable change to experience. Nobody likes to lose their hair. There's just gradual increase in everyday hair loss. Like there's so much hair in my shower, or I have so much more hair in my pillow when I wake up, and this didn't used to happen. It's hair loss that is usually not associated with other symptoms. So if you have like really intense itching or flaking, there might be something else going on. So COVID hair loss is definitely a thing. So people are experiencing telogen effluvium due to a prior COVID infection or just, stress from the overall ongoing 2-year pandemic. I have found that when people have had COVID, like a true COVID infection, and are experiencing hair loss, it's lasting much longer, which is unfortunate. But I tell people just to like really just be patient with it and try to minimize stress around the experience. And this article that I put on the right side was a really great article that was published in The Atlantic. And it was kind of just describing all the different ways that people were losing hair. I mean, it's a really stressful thing that has now become a daily normal part of our lives, and it's manifesting in people's scalps. So it's worth a read if perhaps you experienced this or someone you know did. This other article I found interestingly reported that this post-COVID hair loss was one of the most commonly associated symptoms, and unlike regular telogen effluvium, it's showing up much earlier, which is perhaps responsible for why I and other dermatologists are feeling like it lasts much longer. It's probably because in part it's showing up much earlier as well. Treatment for telogen effluvium, no one likes an answer with this, but It is typically a self-limited disorder and hair should spontaneously regrow. You can certainly help it along with a lot of the treatments that I've already talked about. PRP helps. We have people come in for this all the time at our clinic. Like, I just had a baby and I lost all my hair, or we had someone who had lost a family member to COVID, lost all her hair and kind of just wanted it back. So we do that all the time. You can also use just supplements, minoxidil. Again, there's mixed evidence, but it's one of those things that if you just give it time and you try not to stress out about it, that might be the best thing to do, which I know is like everybody's least favorite piece of advice. I hate getting this piece of advice, no matter what's going on. Hair loss, I pulled my hamstring, something personal is going on. If someone tells me to not stress out about it and give it time, I get angrier. But truthfully, it does apply to this situation. Alopecia areata, moving on, is an inflammatory hair loss. It's typically manifests as a patchy hair loss. It's your own lymphocytes attacking your hair bulbs. Unfortunately, it is typically episodic. So maybe it happens once or twice, and then it should spontaneously resolve. And that's most often what I see. The mainstay of treatment are steroids, either topically or injectable. Like, you can inject them every 4 weeks or so, and I've had very good success with this. People have to come in for a good number of months, but then typically once they heal, and I never see them again, which is it's good, because that means that they're not having any more issues. Patients can put on topical steroids in between their monthly injectable sessions. And the only thing to keep in mind usually is that if this is reoccurring or particularly severe, it can be associated with other autoimmune diseases, hypothyroidism being one of the most common ones. This is a patient of mine actually in La Jolla. He was very kind to let me share his photos. He had a full head of hair a few months ago, more so than what you see on the left. He got, I think, 3 full COVID vaccines. I don't think it was 2 COVID vaccines and a booster. He states he just went and got a 3rd full dose. And that was sort of when he experienced this very severe and kind of sudden hair loss. And he's an evolving case. I don't have any outcomes to let you know, because I'm still working with him. He's seeing a few dermatologists and we're trying to figure out what's going to best help him grow his hair back. But he does have biopsy proven alopecia areata. And the good news is his scalp does not look like it's scarring. So if I get an update on this, I will share it with you all. And I put this slide in here just to illustrate like the variability in all the ways that COVID and COVID vaccines are manifesting in hair or hair loss. There's mixed evidence. Some people have so many case reports of people losing hair after the vaccine, but similarly, people are losing hair after the infection. So it is my professional opinion that the risk of losing hair is not a reason to not get your vaccination. But if for some reason this happens to you, don't feel like you're crazy, just go see someone about it. And we'll work on getting your hair regrown. But it is happening to a lot of people. Moving on to traction alopecia, this occurs from traction, basically, as the name states, and it's just secondary to ongoing trauma. So just tugging, pulling weight from like weaves or something over time can result in this hair loss much later in life. It can be temporary if you make the right interventions. If it starts to happen and those interventions are not made, it can transition to permanent hair loss. What we see in this case is like something called the fringe sign. So that frontal like headband worth of hair is still intact, but perhaps you're losing hair right behind it. The treatment of this is also, it's not particularly complicated, but you just sort of need to not style the hair for a while. So if you can wear your hair naturally, just alleviating that tension will help. And then things like injectable steroids, PRP, minoxidil have also been tried with mixed evidence. This is particularly important for my Black patients, just because genetically their hair is a little bit drier and it has a lot more curls in it. So these helical rims in the hair, if I were to, put a magnifying glass in the hair, that helical curly structure creates a lot more points for the hair to be weak. So that's kind of why that happens. Moving on to scarring alopecias, there's a lot of them, but I'm only going to talk about like the two most common. They're often associated with just some other autoimmune disease. I'm going to talk about CCCA. It has a very long name, central centrifugal cicatricial alopecia, but we all call it CCCA. And then there's LPP, like in planopilaris, and FFA, which is frontal fibrosing alopecia. I wanted to mention that some of those non-scarring alopecias that I mentioned earlier, if they are not appropriately addressed, they can eventually transition over to being a scarring alopecia, like our hormonal one or alopecia areata or even traction. So CCCA is predominantly middle-aged Black women. The exact cause is unknown, but I think again, it's thought to be related to prior hair care practices. What typically happens is that a small patch of hair loss, smooth hair loss, is noted in the vertex scalp, and that it slowly expands outwards until it looks like kind of this big circle of hair loss right in the top of the scalp. The early treatment for early disease is just to minimize hair grooming, period. And it's one of those diseases that has so many treatment options listed because there's not a single one that works particularly well. But steroids have been used with some success. Doxycycline, which is an antibiotic that has this secondary anti-inflammatory effect, has been utilized as well. And then minoxidil has had some success as well. So I used to work at the VA in Texas, and I had a lot of these patients, and the most of them were really happy with just wearing a wig and forgetting about it. I can think of like 4 or 5 women who just didn't want to do anything anymore and were perfectly fine with just sort of wearing prosthetics. Lichen planopilaris, or LPP, and FFA is similar to alopecia areata in that it's an autoimmune attack of your hair bulbs. It affects women more than men, and in particular, it affects lighter skinned women, Caucasian women, more than any other skin type. If there is forehead atrophy, meaning that your forehead's like lighter skinned or maybe thinner, or just looks like you can see more veins, that kind of thing, then you might be worried about FFA. You might have scale throughout the scalp that looks like dandruff, but isn't due to that yeast that traditionally causes dandruff. And this is something to consider if you have really, really severe scalp itch or even like scalp pain or hair pain, which we call trichodynia. There's not a lot of causes of true hair pain otherwise. This is one of the disorders that I think treatment is really challenging for. Steroids have been used in pretty much every form, and then Plaquenil, hydroxychloroquine, is the mainstay of treatment. I've had people have a very good response to that in the past. There's a variety of immunosuppressants that have been used, but typically I'll do steroids and Plaquenil if this is happening to a patient of mine. These are some photos to kind of illustrate what I was talking about earlier. The person on the left has FFA, meaning that their frontal hairline is moving backwards. They have this like scale kind of associated with these hair follicles, and then they're getting these lonely hairs. So if you see some of these terminal hairs that are hanging out all by themselves in the frontal forehead, there's not a lot of causes for that. So the lonely hair sign is usually a good clinical indicator. And on the right photo, we can see this like redness around the hair follicles, which we see in LPP. So again, this was not an exhaustive talk. There's so many causes of hair loss. I just mentioned the ones that I think I see most commonly in clinic in real life. But again, hair shaft abnormalities or excessive fragility of the hair shaft can cause perceived hair loss. Really bad infections, whether it's like fungal infections or even just really severe common dandruff, can make you lose hair in one place or in your whole scalp. Hair is a very common place where autoimmune disease manifests, especially lupus. Follicular disorders, which I skipped for this talk because they're very rare, they're usually very scarring, very severe. If you have this, you typically know that you have it very early on, and more often than not, it's young men who get these diseases. If you've ever had a severe burn or even like scalp radiation, you might lose hair permanently in those areas. And then even weird cancers can show up in the skin, or infiltrative diseases like sarcoid can. So if you have hair loss basically and you're worried about it, just go see somebody, come see me, come see another dermatologist, and we can figure out what's going on. So my conclusions are, for a lot of people, some degree of hair loss is to be expected, unfortunately. But the cause of it, again, can be really multifactorial. there is a wide range of interventions that can be tried, whether you're putting something on or injecting something or taking something by mouth. And there's also surgical interventions. But I think the common theme to all of these interventions is that there is no magic wand. Nothing is quick. By virtue of the hair cycle, everything takes like 4 to 6 months to really make a difference or to tell if it's working or not. And as always, you can consult with the board certified dermatologist like myself if you have any questions or you want to get some treatment on board. These are some of my resources, and I'll take questions if there are any.
Thank you very much for this excellent presentation. I'm going to stop the recording so that people can ask questions freely.